Please start, sir.
I am Dr. Satyaprakash, Professor and Head of the Department of Gastroenterology at the MS Ramaya Medical College and Hospital, Bangalore. Today I am going to discuss about the liver care in geriatric population. This I want to discuss under 4 headings. 1. The liver health in the geriatric population overall. What are the general physiological changes do occur in the geriatric population? That is the first topic, and that's I'm going to start now. We all know that a substantial percentage of morbidity and mortality is attributable to liver disease in the elderly. The number of patients older than 65 with chronic liver disease has increased owing in part to improved management of chronic liver disease as well as advances in the management of cirrhosis of liver and also in the management of extrahepatic systemic diseases. What are the physiological changes that occur with increasing age? In general, the liver function declines with increasing age, and we know that the liver is a complex metabolic organ that is essential for maintaining the whole body homeostasis via regulation of energy metabolism, xenobiotic and endobiotic clearance, and molecular biosynthesis. Therefore, age-related changes in the liver function contribute to systemic susceptibility to age-related liver diseases. The volume and blood flow to the liver gradually decrease with increasing age to as much as 20 to 40% as one gets older. There are changes also in the liver with decreased cytochrome P450 activity that can affect the drug metabolism and increasing the susceptibility of elderly to the drug-induced liver injury. Even the immune responses against pathogens or neoplastic cells are also lower in the elderly. There is evidence to suggest that the hepatic concentration of smooth endoplasmic reticulum decreases with aging, as does the yield of liver microsomes and the activity of several microsomal enzymes such as monooxygenase and glucose 6-phosphatase. Mitochondrial volume is expected to increase, whereas the number of active mitochondria in the liver cells decrease with increasing age. What are the liver function and biochemical tests that are noted in the geriatric age group? There is some evidence that aging affects the liver function. However, most of the studies have shown that significant age-related liver function deficits do not occur, but the liver function continues to be as good as the younger people. Some pharmacokinetic studies have documented a decline in the clearance of certain drugs undergoing the liver metabolism in the aging individuals. The clearance of drugs like aminopyrin, antipyrin, imipramine, many other benzodiazepines, and even caffeine has been shown to be reduced by 10 to 50% with increasing age, and hence this can explain the well-known propensity of the elderly people to develop and experience dose-dependent drug side effects. Another specific liver function altered in elderly individuals is hepatic nitrogen clearance, which is reduced as much as 30% with increasing age. Hepatic secretion of cholesterol has been shown to be increasing with increasing age, whereas the bile acid synthesis decreases. These findings may explain the age is a risk factor for development of cholesterol gallstones. One of the most significant age-related liver function changes in the liver is the liver's regenerative capacity with advancing age. This also explains the liver's decreased ability to recover after severe viral or toxic injury in the elderly patients. Few senescent changes have been shown in the liver function in the humans, and most of them are probably related to decline in the liver size and blood flow. Several specific alterations in the liver function do occur in the elderly. However, these may be associated with the decreased liver capacity to recover from severe hepatic injury and predisposed to specific diseases such as biliary stones. The conventional liver blood tests do not change with age, and abnormalities in the serum bilirubin, serum transaminases, serum alkaline phosphatase, and gamma glutamyl transpeptidase levels should be regarded in the same as the elderly individuals, elderly as the younger persons. What about the liver diseases as you age? Aging is characterized by the cellular senescence and alteration of metabolic pathways. The generation of senescent cells is caused by telomere shortening, DNA damage, epigenetic alteration, oxidative stress, and the mitochondrial dysfunction, resulting in multiple age-associated diseases. Aging also has been shown to enhance the vulnerability to active liver injury and increase the susceptibility of fibrotic response. Aging has a significant impact on the risk and poor prognosis of various liver diseases, including NAFLD, alcoholic liver disease, hepatitis C, and even liver transplantation. Many factors can affect liver metabolism. In aging, the number of hepatocytes and the enzyme activity declines. Diseases that reduce the liver blood flow like heart failure or even shock can also reduce the metabolic potential of the liver. Aging impact directly on all different types of liver cells like hepatocytes, sinusoidal endothelial lining cells, hepatic stellate cells, and even the Kupffer cells. Out of all these, hepatocytes are the parenchymal cells of the liver, which are responsible for majority of the hepatic synthetic function, like synthesis of albumin, fibrinogen, lipoprotein, regulate the fatty acid and carbohydrate metabolism. And also they synthesize cholesterol and bile salts and contribute to drug and xenobiotic metabolism. With aging, there is evidence of genomic instability, and in the hepatocytes, the number of hepatocytes decrease associated with reduced rates of DNA synthesis and repair, in addition to increased number of polyploid hepatocytes. Oxidative stress leads to accumulation of products of lipid peroxidation and elevated nuclear DNA lesions. Impairment of metabolic pathways in the aging liver may be related to hepatocyte senescence. Senescent hepatocytes have increased lipid droplet accumulation, decreased mitochondrial oxidizing capacity, and increased production of reactive oxygen species. And similar findings are found in steatotic livers, providing an explanation for the increased incidence of NAFLD in older people. Cells of the liver sinusoidal endothelial cells, are a significant but under-recognized risk factor for the development of age-related cardiometabolic disease. Endocytosis in the LSECs become dysfunctional with older age. The deposition of circulating products in the form of giant molecules outside the liver is augmented, which may subsequently increase the risk of age-related diseases including diabetes, atherosclerosis, arthritis, and even neurodegenerative disorders. In summary, what are the various morphological and functional changes that occur in liver as you age? 1. Reduced liver weight, reduced blood flow to the liver, loss of metabolic function, loss of detoxification, decreased growth factor expression. Aging decreases regenerative ability, which significantly delays the restoration of liver function. Aging of the liver mainly affects the sinusoids and Kupffer cells. There is something called pseudocapillarization manifested by reduced sinusoidal fenestration and subendothelial collagen deposition that causes reduction in the oxygen-dependent hepatocyte function such as oxidative drug metabolism. The liver mass in older adults is somewhat reduced and the liver blood flow is also decreased. This reduces the clearance of rapidly clearing drugs, but the clearance of slowly clear drugs is not affected. In relatively healthy older people, the results are as good as those in the younger age group. There is an increased prevalence of hepatocyte C associated cirrhosis and hepatocellular carcinoma in the elderly population, and there is an increased prevalence of gallstones among older people, especially among the females. Thank you very much. So this is the first one. I'll start the second topic. I am Dr. Satya Prakash, Professor and Head of the Department of Gastroenterology at the MS Ramaya Medical College and Hospital, Bangalore. Today I am going to discuss the metabolic disorders, alcohol-related diseases of the liver in the geriatric population, the pathophysiology and the diagnosis. The very old are more likely to have signs of liver disease on presentation than the young. The common presentation in the older patients are non-specific often, and they include general weakness, anorexia, and abdominal pain. In those aged over 70, just giddiness may be the most common presentation. Jaundice, edema, and ascites are more common in the older than in the young, suggesting a more severe stage of alcoholic liver disease if it is present at the time of presentation. NAFLD included steatosis, non-alcoholic steatohepatitis accompanied by inflammation, liver fibrosis, and liver cirrhosis. All these four are present as a part of NAFLD. Insulin resistance is a major component of metabolic syndrome, which is often observed in elderly individuals. Aging accompanied by abdominal obesity and excessive visceral fat causes insulin resistance and increased secretion of pro-inflammatory cytokines, and subsequently results in the metabolic syndrome and type 2 diabetes mellitus. Molecular mechanisms for the accumulation of excessive fat in the liver and damage to hepatic cells due to aging include increased reactive oxygen species, DNA damage, telomere shortening, a decreased autophagy, increased M1 macrophages, inflammatory responses, and activation of nuclear factor Kb pathways. Insulin resistance, which is known to be a primary responsible factor for NAFLD, is major component of the metabolic syndrome, which is often observed in elderly people. Aging, which is accompanied by abdominal obesity and excessive visceral fat, causes insulin resistance and increased secretion of pro-inflammatory cytokines, and subsequently results in the metabolic syndrome and diabetes mellitus type 2. The prevalence of NAFLD shows the increased tendency as one gets older. The elderly people aging more than 65, the overall prevalence of NAFLD is about 35% in India. What about alcoholic liver disease? The alcohol metabolism ability of elderly people is reduced over a period of time due to a decrease in the activation level of alcohol metabolic enzymes, and the blood ethanol concentration is elevated owing to reduced distribution of volume of water in the elderly. Besides, alcohol toxicity risks may increase due to alteration of alcohol metabolism by taking certain medications, which is a part and parcel of older age. With aging, the function of mitochondria decreases, and if it is accompanied by diabetes or metabolic syndrome, the fatty liver will only increase. An increased generation of reactive oxygen species I'll just repeat the alcohol metabolism. The alcohol metabolism ability of the elderly people is reduced over a period of time due to a decrease in the activation of alcohol metabolic enzymes, and the blood ethanol concentration is elevated owing to reduced distribution of volume of water. Besides, alcohol toxicity may increase due to alteration of alcohol metabolism by taking certain medications. With aging, the function of mitochondria decreases, and if it is accompanied by diabetes or metabolic syndrome, the fatty liver only will increase. As an increased generation of reactive oxygen species and a weakened oxidation defense mechanism increases the oxidative stress, and also the gut leakiness boosts the secretion of tumor necrosis factor by the Kupffer cells, which accelerate the progression from fatty liver to steatohepatitis. Such factors can accelerate the generation of liver cirrhosis by activating the transformation of hepatic stellate cells into myofibroblasts. What are the symptoms of alcoholic liver disease? The clinical symptoms of alcoholic liver disease among the elderly are more or less similar to the younger individuals, but their prevalence and complications is higher than in the other age groups. Among patients with alcoholic liver disease older than 60, about 79% suffer from complications such as liver cirrhosis. 40% of patients with alcoholic cirrhosis have alcohol hepatitis, and mortality rate of patients with alcoholic hepatitis is anywhere between 15 to 25%. What are the complications we foresee in elderly individual in these two conditions, like NAFLD and alcoholic liver disease? As we say, aging is related to a bad prognosis of alcohol hepatitis. Alcohol accelerates the chronic hepatitis caused by hepatitis B or even hepatitis C and other liver diseases such as NAFLD and hemochromatosis. For those infected with hepatitis C virus and hepatitis B virus, alcohol consumption can only advance the liver cirrhosis progression and increase the hepatocellular carcinoma risk. For obese people, alcohol intake elevates excessive fat accumulation in the liver and worsens the liver damage by increased secretion of TNF alpha and cytochrome P450-2E1. Additionally, aging increases the risk for comorbidities, especially elderly people are often under medication with other drugs. As ethanol and most medicines are metabolized by the cytochrome P450 dependent microoxygenases in the liver, elderly patients with alcoholic liver disease have higher propensity to develop hepatotoxicity because of the interaction with other drugs. The primary treatment of alcoholic liver disease is to stop drinking and provide sufficient nutrients and vitamins. However, the glucocorticoid treatment can help those patients with moderate alcohol hepatitis whose MADRS discriminant function scores are higher than 32. For those who have a contraindication for steroids, pentoxifylline, a TNF alpha inhibitor, can be considered as an alternative treatment. This is the second one. Hello, I am Dr. Satya Prakash. I am the professor and head of the Department of Gastroenterology at the MS Ramaiah Medical College Hospital, Bangalore. I am going to discuss about the problems of geriatric population with liver disease. Now I am going to discuss the infectious diseases of the liver in the geriatric patient concerned to liver disease. Geriatric group of patients do develop hepatitis A, hepatitis B, and hepatitis C infections, which are hepatotrophic viruses, apart from other infections which also occur in the geriatric age group, but my time is restricted only to discuss these 3 infections in the geriatric age group. Hepatitis A virus infection is usually a milder disease. Acute hepatitis A is rarely encountered in patients older than 65. Middle-aged and older people are more susceptible to severe form of acute hepatitis A infection and are more likely to have serious complications. Hepatitis A virus vaccination is recommended strongly for elderly patients, elderly people traveling to areas which are endemic for hepatitis A virus, although the cost effectiveness of vaccination has not been evaluated. Coming to hepatitis B virus infection, similar to acute hepatitis A virus infection, even acute hepatitis B virus infection is also rarer in individuals older than 65. Sporadic cases and rare outbreaks can do occur. Although 5% of immunocompetent adults can have an acute hepatitis B virus infection, overall progress to chronic infection and the natural history of hepatitis B virus infection seems to be altered in elderly individuals. Hepatitis B virus vaccination produces a lower antibody response in older than younger patients, probably because of an age-related decline in immune function. Incorporating the highly immunogenic pre-S antigens into the hepatitis B virus vaccine has improved the vaccine's immunogenicity and may lead to increased seroconversion rates in the older patients. Coming to hepatitis C virus infection in the elderly age group, those who are aged over 65 and higher than younger people who have acquired the infection from blood transfusion or surgery before 1990 are more likely to get the chronic hepatitis C infection, which is more commoner than the intravenous drug abuse in the elderly. The age of the patient at the time of hepatitis C virus infection diagnosis has proven to be a risk factor for the progression of liver fibrosis, liver cirrhosis, and even hepatocellular carcinoma. If a patient is more than 40 years old at the time of diagnosis of chronic hepatitis C virus infection, their progression to liver fibrosis is much faster than those who are under 40 years of age. And those aged more than 65 years, the relative risk of severe liver fibrosis is almost 3.78 times higher than that of those who are under 65 years of age. Elderly people commonly show liver fibrosis. They need antiviral treatments. Meanwhile, majority of them suffer from medical illnesses. They cannot take the antiviral drugs and they develop side effects frequently because of the medication. And hence, the elderly patients with chronic hepatitis C virus, the antiviral treatment should be determined to consider the progression of the liver disease and the liver fibrosis and the expected lifespan and the comorbidities. That is the third topic. Okay. This I wanted to repeat this: metabolic disorders and alcohol-related liver diseases, pathophysiology, and the diagnosis, because there is some confusion. In your editing, we do this. The third topic. Hello, I am Dr. Satya Prakash, Professor and Head of the Department of Gastroenterology at the MS Ramaya Medical College and Hospital, Bangalore. I am going to discuss about the liver diseases in the geriatric population. I am going to discuss metabolic disorders and alcohol-induced diseases of the liver in a geriatric patient, pathophysiology, and the diagnosis. The very old are more likely to have signs of severe liver disease on presentation than young. The commonest presentation in the older patient are non-specific and include general malaise, anorexia, and abdominal pain. In those aged over 70, just giddiness may be the only presentation. Jaundice, edema, and ascites are more common in older than in the younger patients, suggesting a more severe stage of alcoholic liver disease at the time of presentation. NAFLD includes steatosis, non-alcoholic steatohepatitis accompanied by inflammation, liver fibrosis, and liver cirrhosis. Insulin resistance is the major component of metabolic syndrome, which is often observed in the elderly patients. Aging, accompanied by the abdominal obesity and excessive visceral fat, causes insulin resistance and increased secretion of pro-inflammatory cytokines, and subsequently results in the metabolic syndromes and type 2 diabetes mellitus. Molecular mechanisms for the accumulation of excessive fat in the liver and damage to liver cells due to aging include increased reactive oxygen species formation, DNA damage, telomere shortening, a decreased autophagy, increased M1 macrophages inflammatory response, and activation of nuclear factor Kb pathways. Insulin resistance, which is known to be a primary cause of NAFLD, is a major component of metabolic syndrome, which is often observed in the elderly patients. Aging, which is accompanied by abdominal obesity and excessive visceral fat, causes insulin resistance and increased secretion of pro-inflammatory cytokines, and subsequently results in the metabolic syndrome and type 2 diabetes mellitus. The prevalence of NAFLD shows an increased tendency as one gets older. The elderly people aged more than 65 years, the overall prevalence of NAFLD is approximately 35% in India. Alcoholic liver disease, the alcohol metabolism ability of the elderly people is reduced over a period of time due to decreased activation of alcohol metabolic enzymes. And the blood ethanol concentration is elevated owing to reduced distribution of volume of water in the elderly. Besides, alcohol toxicity risks may increase due to alteration of alcohol metabolism by taking certain medications. With aging, the function of mitochondria decreases, and if it is accompanied by diabetes or metabolic syndrome, the fatty liver will increase. An increased generation of reactive oxygen species and a weakened oxidation defense mechanisms leading to increased oxidative stress, and also the gut leakiness boosts the secretion of tumor necrosis factor alpha by the Kupffer cells, which accelerate the progression from fatty liver to steatohepatitis. Such factors can accelerate the generation of liver cirrhosis by activating the transformation of hepatic stellate cells into myofibroblasts. The clinical symptoms of alcoholic liver disease among the elderly are similar to their younger counterparts, but their prevalence and the complications is higher than the other age groups. Among patients with alcoholic liver disease older than 60, about 79% suffer from complications such as liver cirrhosis. 40% of patients with alcoholic cirrhosis also have alcohol hepatitis, and the mortality rate of patients with alcoholic hepatitis is anywhere between 15 to 25%. Aging is also a bad prognosis for alcoholic hepatitis. Alcohol accelerates the chronic hepatitis caused by hepatitis B and hepatitis C virus, and also other diseases of the liver such as NAFLD and hemochromatosis. For those infected with hepatitis C virus and hepatitis B virus, alcohol consumption can advance the liver cirrhosis progression and increase the hepatocellular carcinoma risk. For obese people, alcohol intake elevates the excess fat accumulation in the liver and worsens the liver damage by increased secretion of TNF-alpha and cytochrome P450-2E1. Additionally, aging also increases the risk for comorbidities, as elderly people are often under the medication for other drugs, as ethanol and most medicines are metabolized by the cytochrome P450 dependent monooxygenases in the liver. Elderly patients with alcoholic liver disease have a higher risk for hepatotoxicity because of the interaction with other drugs. The primary treatment of alcoholic liver disease is to stop drinking, provide sufficient nutrients and vitamins. However, the glucocorticoid treatment can help those patients with moderate alcoholic hepatitis whose MADRS discriminant function scores are higher than 32. For those who have a contraindication for corticosteroids, pentoxifylline, a TNF-alpha inhibitor, can also be considered as an alternative treatment. That's about the second one. The last question. Hello, I am Dr. Satya Prakash, Professor and Head of the Department of Gastroenterology at the MS Ramaya Medical College and Hospital, Bangalore. I am discussing about the liver diseases in the geriatric age group. I am coming to the discussion of managing the liver disorders in the geriatric patients. The liver disorders are broadly categorized into management of non-alcoholic fatty liver disease, management of infective liver disease, and management of alcoholic liver disease in the elderly. Management of NAFLD in geriatric age group. The current treatments of NAFLD are to control body weight by changing the lifestyle and improve the insulin resistance. Exercise and diet therapy for the elderly can reduce the fat accumulation in the liver and improve hyperlipidemia, hypertension, and insulin resistance. Metformin and thiazolidinediones are the insulin sensitizers, which are well known to the physicians. The metformin is effective in reducing the body weight and improving the insulin resistance. However, its histological effect on improving the necroinflammation in the NASH has not been proven. Thiazolidinediones, which is a PPAR gamma agonist known for improving the insulin resistance of the fat cells and also the liver. In NAFLD, thiazolidinediones reduce the fat accumulation in the liver and show some improvement in the inflammation, but they have failed to improve the liver fibrosis. Thiazolidinediones are not recommended to elderly patients with heart failure as they cause significant increasing in the body weight. Bariatric surgery is also recommended for those with a BMI of over 35 kg per square meter in type 2 diabetes mellitus, and also bariatric surgery is known to improve the necroinflammation and fibrosis in the liver by reducing the body weight. So they have a definite role. Management of infections in the geriatric age group. It has been reported the supplementation of vitamin B12 and vitamin D increases the response to antivirals and improves the sustained viral response rates. As the elderly people lack these vitamins, they need to take the supplements. Earlier, they used to have protease inhibitors and interferons for use of chronic hepatitis C virus infection. Now, we have an advanced directly acting antiviral drugs which are which can be safely given irrespective of the viral load or genotype. So they are very safe and they could be given for a shorter duration. Directly acting antiviral drugs are better for chronic hepatitis C virus infection. For hepatitis B virus also, the current recommendations are only one of either entecavir or tenofovir. Tenofovir alafenamide is supposed to be safer in the long run with the renal sparing toxic effect. So the management of hepatitis B and C have become more simplified in the geriatric age group now. What about the management of alcoholic liver disease? Again, I wanted to emphasize the primary treatment of alcoholic liver disease is to stop drinking and provide sufficient nutrients and vitamins. However, a recommendation of glucocorticosteroids can help patients with moderate alcoholic hepatitis where MADRS discriminant function scores are higher than 32. For those who have a contraindication for steroids, pentoxifylline, a TNF-alpha inhibitor, can be considered as an alternative treatment. So that's it. Thank you very much. That completes the 4 questions and the thing.
Okay, sir. Perfect, sir.
So there is no need to redo anything. Everything is fine.
Everything is fine, sir.
Okay. Can I leave?
Yes, sir. Yeah, yes, sure, sir. Thank you so much, sir.
Thank you so much.